How's that? All right, everyone can hear me? Great. All right, so I want to introduce our speakers for today, our experts. We have Ciannah Correa, who is a research fellow at the Medicare Policy Initiative. We're so happy to bring her to our team recently. She does research and policy analysis for us at MPI. We have Jackson Thein, who's the Director of Government Relations at Waxman Strategies, where he works with members of Congress and their staff on healthcare financing policies to lower costs for patients and broader healthcare system. We have David Meyers here from Brown University, and he is from Brown University Center for Advancing Health Policy Through Research. You've probably heard of them, or they're great research. They do studies on payment and delivery system reform with a focus on Medicare. And lastly, my colleague Neil Patil, who is the policy director and leads our technical assistance to Congress and policymakers at MPI. So with that, I'm going to hand it over to Ciannah for our first presentation.
Great. So today I'll be speaking with you all about the Improving Seniors Timely Access to Care Act, which is bipartisan legislation. It's been introduced by a lot of folks on both sides of the aisle in both the House and in the Senate. And it's a very timely piece of legislation, especially given public discourse and a lot of attention on prior authorization and denials of care, and just generally a little bit of distrust in managed care overall. So this legislation, next slide, please, aims to improve transparency and oversight of prior authorization and, learn more from the plans there. It aims to improve enrollee protections with prior authorization. It looks to modernize and start looking towards artificial intelligence and the effects of AI in prior authorization. And I'll also talk a little bit about operationalizing this bill and other considerations to keep in mind. So this slide is going to be a good level set because CMS has taken a lot of steps actually to improve prior authorization already. And those are going to be here on the left-hand side. It's not an exhaustive list, but I wanted to highlight some of the key comparisons here. We do have a very large document that it does look at all the different comparisons between CMS and the proposed legislation on our website. So if you'd like to look, it's there for you as a tool. But the left-hand side has what has been finalized in regulation, and the right-hand side are what the bill looks to put into statute and start moving forward to. And so a lot of these are very similar, as we can see. Authorization is a really big one here. CMS has finalized regulation requiring MA plans to essentially create a electronic prior authorization programming interface that is compatible with FHIR. So they're a bit of a standard that's being set there. And the legislation would do something similar, just kind of puts into statute that this needs to be done and regulated by CMS. It needs to be enforced. And on the reporting requirement side of things, CMS has taken steps to start requiring MA plans to report prior authorization metrics like approvals, overturns, et cetera, at the contract level and on aggregate for all items and services. So that CMS is essentially getting a pretty large snapshot of what's going on at the contract level. But this legislation would take that a step further. It'd be a little bit more detailed of what plans would have to report. And that's because it'd be at the plan level, and it would have to be categorized by all items and services. So right now at the contract level plan, we can't really see what's happening at the local level, and enrollees aren't necessarily able to see what their plan in their zip code in their county is actually how they're actually performing on those prior authorization metrics. The legislation would make that visible and would require that level of reporting. Also of note is that this legislation would require any plans to report on prior authorization metrics when AI is involved in the decision-making, which is not something that is currently required. So that would be a pretty notable step towards modernizing our regulation and oversight there. There's a lot on this slide, so I'll go ahead and skip forward to some of the other key differences and key changes. Is The legislation looks to include plan enrollees in the prior authorization program decision-making, and also explicitly clarifies CMS authority to establish real-time decision processes for MA plans to follow, which is a pretty big deal in this arena, and I'll get into that in this next slide. Okay, great. So what is a real-time decision? What it sounds like. It's when a decision is made on prior authorization for typically routinely approved items and services. And the decision is able to be made in minutes to hours rather than days, which is huge. It's the difference between somebody getting care the next day or the next week. And that has to be done through electronic prior authorization. It's the way to do it quickly. And so now with this, if this bill were to pass through, it would require CMS to develop a process for MA plans to follow to do and implement those real-time decisions. So create a standard there. And CMS also has to analyze in a report to Congress what their proposed process does to improve access to care, operational efficiencies, and how it addresses reductions or reduces health disparities for low income and rural enrollees. So that's a big difference and a new change there. Also in this report is a requirement for CMS to look at how the use of automation and AI in prior authorization affects patient access overall. And as well, specifically on rural and low-income enrollees, which is a new step towards looking at AI again, which CMS has not yet done. So just some quick things to keep in mind as you're thinking about this legislation, if it might be improved if it might be included in an end-of-year package. It has been scored at $0 for 2024 by the CBO, which is a big difference from its prior score of 16 billion. From the stakeholder perspective side, both MA organizations such as like BMA and provider and hospital organizations have written out and that said that they are in favor of this bill. So having two different parts of the market in line on this topic is a pretty big thing, and not too often, we don't see it too often. So it's kind of exciting to see it here. Operationally, implementing this legislation would be a little bit more feasible today than it would have been a couple years ago, because as we were talking about earlier, CMS has already put into place and finalized a lot of regulations that move in the same direction that this legislation wants to go. So MA plans are already gearing up and ready to report those prior authorization metrics at the contract level. So they'll just take it a step further and go at the plan level, et cetera. And so it's a little bit less of a heavy lift there. Politically, it is bipartisan and has previously been passed by the House of Representatives unanimously. So that could be an indicator of what might be to come. And I'm running out of time here. So really quickly, just for some context, the America's Health Insurance Plans have done a voluntary pledge to kind of work towards prior authorization improvements, especially on that real-time decision front. And also there is another prior authorization bill, the Reducing Medically Unnecessary Delays in Care Act, which is a little bit of a different focus, more on using specialty or certified physicians to assess prior authorization, but happy to get into that later if folks have questions on it. I'll hand it over now to Jackson to talk about no upcode.
All righty, good to speak with you all today. So my name is Jackson Thein. I'm with Waxman Strategies. We're a mission-driven consulting firm based in Washington, D.C. I'm here just on behalf of myself and Waxman, not necessarily our clients. And I'm going to be speaking about the No Upcode Act to help address overpayments in Medicare Advantage. So really necessary to understand the issue of what no upcode does, just to have some level setting here on how plans are actually paid in Medicare Advantage. So I'm sure for some of you in the room, this will be a review, but MA plans are paid on a per enrollee basis, what we know as capitation. However, what that exact amount is really complex and is based on a few different factors. So it's a system of benchmarks, bids, quality bonus adjustments. But for today, we're going to focus on that last point here, which is risk adjustment. So risk adjustment is really defined as this system where annual payment for a beneficiary in a plan is based on their health status. And that really derives from this idea that enrollees would drive additional healthcare costs for plans to cover them. And because of that, and because the government is providing for that coverage through MA, the government will pay more for that enrollee. So in part, this is captured by coding for a patient's individual medical diagnoses, which will be the heart of what we talk about today. And so just wanted to briefly define here at the bottom too what we mean by the term upcoding. And I put it in quotes for a reason because it can vary based on who asked. But essentially what this means is that it's a system where we're systematically assessing patients for additional codes that they may not necessarily have. Essentially, patients are being coded for additional health conditions at the end of the day. That's excellent. And so the most simple way that you can think of coding actually playing out is for an individual to seek medical care. They present to their provider and they're coded for that diagnosis, for that condition that they have an encounter with their provider on. But for the sake of understanding no upcode, I'm going to focus on two different aspects in which patients can have codes attributed to them. The first is the health risk assessment, or the HRA. So I want to clarify from the start here that HRAs are actually required under Medicare Advantage, but they are surveys or interactions with enrollees to collect information on their health status, health conditions, et cetera. One of the notes here just about HRAs is that they can display in different forms. So they can actually occur if an individual's provider at a facility. They can also occur via telehealth. And then the one where it comes up the most, I think, in the upcoding debate is on this idea that an HRA can actually occur in a patient's home. So HRAs, again, are something that are a common aspect of MA, but they have been critiqued for what they can mean for upcoding. The first, just basic point, is that they can lead to coding for diagnoses that a patient may not have. Beyond that, too, there are some concerns about plans using contractors or contracting out essentially for these HRAs to occur. And so there is a question there about whether HRAs are actually leading, one, to follow-up care for that patient, and two, whether it's leading to better care coordination at the end of the day. The second aspect I'll talk about is the process of chart reviews. And so these are retrospective reviews of an enrollee's medical records, essentially with the goal of collecting codes that may not have been captured previously. Some additional concerns that have been raised with chart reviews is, again, similar to HRAs, the process of using hired vendors to conduct chart reviews. And then a recent issue that's been raised in some critiques is the use of AI to do chart reviews. And so again, what both of these really get at is this idea that capturing additional codes will lead to higher capitated payments from the government for an enrollee. So I wanted to make this a little interactive, considering we're diving into MA. So I put a few screenshots here just to illustrate the fact that these are not behind the scenes processes. These are something that you can find a lot of information about online. So Signify Health, they are a large contractor for in-home health risk assessments. You can see they have some information online about the benefits, FAQs, et cetera. Insurers themselves will also talk about the in-home health risk assessment. There's a screenshot there from United Healthcare. And then this one on the right is for a company called Charta. They are a company that markets themselves to help with chart reviews. Their website is very clear that they use AI to do so. So again, not secret things that are going on behind the scenes. And then I just wanted to note here too that this issue of upcoding is well documented. It's also been documented for several years. I'm sure many in the room have remembered the Wall Street Journal investigations into upcoding, as well as health risk assessments overall. They've also been the source of investigations and reports by HHS OIG. You can see that one on the right actually dates back to 2019, so not all super recent as well. And then this report at the bottom, I see the text is a little blurred, but if we click once forward, date for that is 2009. So this is something that actually they have been discussing since the first Obama administration. So that specifically gets us into this aspect of no upcode and what it actually seeks to do. So there's two main thrusts for the bill. The first one is coding reforms. So essentially what the bill seeks to do is exclude diagnoses that are solely collected from chart reviews and HRAs in risk adjustment. It also would require 2 years of diagnostic data to inform the risk adjustment model. Generally, how you can think about that is smoothing the risk adjustment model between fee for service, which funding is based off of for these plans, and MA overall. But then there's also some aspects of the coding adjustment. So it's well recognized and documented that MA plans code patients higher than what would be in traditional Medicare. The reason for that is that there is an incentive to do so. And because of that, CMS by law is actually required to downward adjust risk scores to address for that. The minimum that CMS has to apply is 5.9%. They can go higher. They have never chosen to do so. So what no upcode actually seeks to do as well is require that that adjustment fully account for the coding pattern differences between MA and traditional Medicare. It would also allow for that adjustment to occur at the plan or contract level. Currently, that adjustment is across the board. So what that seeks to do is actually allow for some variation. How plans could be assessed for their coding pattern differences. Small plans that perhaps are not coding as aggressively could get a smaller adjustment. Plans that are aggressively upcoding could get a larger one. So I just want to note really quickly here that these policy provisions have shown up in other bills. Representative Spartz included one in a Medicare reform bill. And then Representative Schweiker as well introduced MA reform legislation earlier this year. He included the diagnostic data, HRA, chart review reforms in there too. Estimated savings from the bill are to be 200 to 270 billion over 10 years. That's from Senator Cassidy's office. Some questions, of course, remain on implementation about how these policies would be brought into the risk adjustment model. And then finally, just wanted to say, there is a lot of conflation of these terms of upcoding and overpayments. Really, upcoding is just one piece of that puzzle. And as you'll hear today, a lot of different areas in MA that may require some reforms.
Awesome. Hi, everybody. I will pick up where Jackson left off to talk about another one of those areas where there's a lot of payment and there's a lot of argument that there could be an opportunity for overpayment, which is this issue of duplicate payments between the Veterans Health Administration and the Medicare Advantage plans. This sounds like it would be sort of a niche issue, but once we get into sort of the amount of money at the line here, it's actually pretty substantial what this means for Medicare spending. So my name is David. I'm from Brown University. I help run our Center for Advancing Health Policy through Research. We conduct economic research and then try to translate those results into ways that are useful for policymakers. And so thank you for having me here. Next slide. Just to disclose, this work is partially funded by the VA and by Arnold Ventures. I also am a part-time senior advisor at CMMI. This work does not reflect the views of the federal government. It just reflects my own views. Next slide. So many veterans, not all, but many veterans are eligible to receive healthcare services from the Veterans Health Administration, which is a single payer system. It's available across the country that provides comprehensive healthcare benefits for veterans, both hospital care, outpatient care, surgeries, medication, whatever a veteran might need. They can usually get most of those services from the VA. At the same time, veterans who are eligible for VA services can also enroll in other insurance products, whether it's through commercial insurance, Medicaid, or importantly, veterans who are over the age of 65 or who have a long-term disability can also enroll in Medicare Advantage or traditional Medicare. In most cases, excuse me, the VHA pays for care that the veterans receive from the VA. They get it from the VA budget, provides for those services. And if a veteran receives care that is covered by one of the secondary payers, then the secondary payer will pick up covering for that service. Next slide. The issue where this becomes a problem is with the capitated payments in the Medicare Advantage program. As Jackson talked about, MA plans are paid on a capitated rate to cover all the comprehensive healthcare needs that beneficiaries need in a year. What's happening, though, is many veterans who are enrolled in both the VA and enrolled in a Medicare Advantage plan are receiving close to 100% of their care from the VA. they're not actually receiving much from the MA plans aside from some supplemental benefits and wraparound services. But the MA plan still receives its full capitated payment for taking care of those beneficiaries. So the plan is paid as if it's on the hook for all the medical needs that a veteran might actually require, when in reality, the veteran is often receiving most of their care from the VA, and the VA is statutorily not allowed to seek reimbursement from MA plans. This is different. The VA can go to commercial insurance plans to seek reimbursement if their veteran has dual coverage, but there's several locations in the statute where the VA is not allowed to bill the Medicare program for those services. It's not an issue in traditional Medicare because the payments aren't capitated, but in MA, the payment continues to flow either way. Next slide. And this is actually a really major dollar amount difference. So these are actually hot off the presses. These results should be published in the next month or so. They were accepted. What we find is in the last 5 years, the VA has paid for $86 billion in coverage for veterans who are receiving most of their care from the VA, while those veterans are still leading to payments going to Medicare Advantage plans. So these cannot be recouped from the VA. It's largely driven by an increase in community care, which is care that the VA contracts with community providers for. And a lot of it is happening in VA affinity plans. So a lot of MA plans will have VA specific plans that they know members won't use much care that the plan is paying for because most of it will get paid for by the VA. And it was just about 22 billion alone in 2023. And this is over 20% of the VA's entire budget is being spent on these beneficiaries. So there's a lot of money on the line here. Next slide. So there are two policy ways that you could go about addressing this issue. One is you could potentially reduce the payments that plans are getting in their capitated payments. This is similar to when veterans receive when beneficiaries receive hospice care. MA plans get a cut to their capitated payments, not paying for as much care because traditional Medicare covers hospice. Something similar could be set up for veterans where the plan gets paid less for the veterans that they take care of, although it could be a little bit complicated to sort of set those rates. The other way that this could potentially be addressed is through legislation that would allow the VA to seek reimbursement at a negotiated rate or at a traditional Medicare rate from MA plans for the spending. So the MA plan still gets paid their full capitated amount, but at least the VA gets the budget relief and the federal government isn't paying for the same services twice. Next slide. So there's one bill that I'm here to talk about today that has been sort of introduced to address this, the GUARD Veterans Healthcare Act. There's a lot of veterans acts that include the word GUARD in it, so it's specifically the GUARD Veterans Healthcare Act. And it's a bipartisan piece of legislation that's been introduced that follows the second policy strategy. Essentially what it does is it allows the VA to seek reimbursement from MA plans, and it includes several protections to ensure that things don't get caught up in sort of administrative processes to allow those reimbursements to continue to flow. We've done some estimates. It hasn't been scored by CBO yet, but it looks like based on the spending trajectories in the MA program, it could be over $300 billion that this potential legislation could save the overall federal budget if it were to be sort of implemented over a 10-year period of time, just with the growth of the MA program among veterans. Next slide. There are some trade-offs to this legislation that are important to sort of think about. This would mean that the plans are getting paid less for taking care of these veterans, and plans may say that it'll lead to sort of a reduction of benefits, and this probably could happen in some ways. But a lot of evidence finds the pass-through of payment cuts to MA plans don't often result in huge disruptions in what ends up being provided, since the MA program is still a competitive market, and if a plan cuts its benefits too much, it might lose too much member share in a given market area. Plans may also change their bidding behavior. If they're now on the hook for more spending, they might submit higher bids to the VA, to the Medicare program. But we've looked at some historical bid data, and the plans that have high VA enrollment tend to bid at about the same rates as other plans, and they bid sort of right at the benchmark level. So there's actually not a whole lot of additional spending that could come from that sort of process. And the last thing that sometimes gets brought up is that CMS already has a VA adjustment to the benchmark payments. That basically what CMS currently does is in counties that have high VA and TRICARE and other sort of military affiliated enrollment, it actually, because as a result, there'll be lower traditional Medicare spending in those counties because there's more spending sort of at the VA. The MA plans or CMS actually increases the benchmark rates in those areas where this is going on. And so even though there is this payment adjustment that sometimes people talk about as like, oh, we don't have to fix this larger double payment issue, what this benchmark actually does, adjustment could actually make the issue worse if most of these MA focused VA plans or if the MA plans focused on veterans are in areas with high VA penetration, then this will actually drive up spending even more potentially on these duplicative payments. So I'll stop there. Happy to chat about it more, and thank you so much for having me.
Like that. Well, hi everyone. My name's Neil Patil, and my colleagues today, they covered most of the major pieces of legislation that we should be thinking about as we're approaching the end of the year. I'm going to cover just 3 other pieces of legislation that we did not talk about today. So these bills that I'll cover, that I'll talk about in a second, sort of cover a couple different major areas. The first one is accurate provider directories. There have been a lot of reports recently that, frankly, provider directories under MA plans are just not very accurate. Either they're including outdated information or including providers who are no longer in the network. This is a lot of times referred to as ghost networks. Next, supplemental benefit transparency. So under Medicare Advantage, plans can offer additional benefits that are not covered under traditional Medicare, which are referred to as supplemental benefits. And these are everything from dental, vision, and hearing to potentially food and produce or transportation benefits. One of the issues around that is that there have been a lot of reports that some of those benefits are being underutilized. And there's not a lot of transparency around the costs of those benefits as well as payments for those benefits. Next, enrollee cost sharing protections. This will really relate to the provider directories piece, but making sure that, if enrollees do receive inaccurate provider directory information, that they're held harmless to that. And lastly, provider reimbursement rates. We have heard a number of issues on providers saying that their reimbursement rates are simply too low or not where they should be relative to traditional Medicare. There's a lot of confusion around that because currently there is a statutory non-interference clause where CMS is actually not able to set or establish any kind of payment rate under Medicare Advantage. And so these payments between the plans and the providers are really based on those two entities negotiating and coming to some kind of contractual arrangements. Great. So these are the 3 pieces of legislation that we'll cover today. And I'll go through them kind of quickly, but I'm happy to answer questions afterwards. So the first one is the Requiring Enhanced and Accurate Lists or Real Healthcare Providers Act. This is a bipartisan piece of legislation. It's been introduced by Senators Bennett, Wyden, and Tillis on the Senate side, and a number of Ways and Means members of Congress on the House side as well. This is really the bill that's getting into accurate provider directories. Next, I'll talk a little bit about HR 5243. It actually doesn't have a title yet, but it deals with supplemental benefit transparency. And this is introduced by Representative McClellan from Virginia. This is really where we're talking about increasing transparency, getting more information around supplemental benefits. And then lastly, this is kind of the newest piece of legislation that was introduced in July of this year. This is the Prompt and Fair Pay Act. It is bipartisan legislation from Representatives Doggett and Murphy on the Ways and Means Committee. And I will, talk a little bit about kind of what this is doing, but really this is focused on ensuring that provider payments are pretty much in line with Medicare fee-for-service payments, and also making sure that providers are paid within certain timeframes. All right, so on this first bill, this one was the one dealing with accurate provider directories, the Real Healthcare Providers Act. As I mentioned, this is bipartisan legislation. And this aims to prevent inaccurate provider directories and hold MA plans accountable for those inaccuracies. So how does it do this? The first piece is verification. So it requires MA plans to actually go through their directories and verify that that information is correct for every single provider every 90 days. Now, what happens if they find out that a provider's out of network? They are required to eventually take that, remove that within 5 days. If they find inaccurate information, again, they have about 5 days to sort of fix those issues. It also increases the amount of information that's included in provider directories. So it requires things like whether or not the provider is accepting new patients at the time, or whether they have certain linguistic or cultural capabilities. It also has some cost sharing limitations. So like I said, if an enrollee goes on their provider directory, they see, oh, this doctor is in network. They go see the doctor and it turns out they're out of network. The MA plan is required to hold them harmless and make sure that they're only paying in-network cost sharing. Next slide. All right. There's also some analyses around provider directories. So MA plans are required to kind of go through their provider directories, analyze, the inaccuracies of them, and submit that information to CMS. And CMS actually is going to be required to then post accuracy reports for every single one of these MA plans to give it an actual score of how accurate their provider directories are. And lastly, it also requires a GAO study around those accuracy scores. All right, and flying through these next ones, but this bill is the one that I mentioned deals with supplemental benefits. And so it really aims to increase data transparency around supplemental benefits. And how does this work? Well, currently, MA plans are required to submit plan level information on supplemental benefits. So things like what's the average cost sharing for certain benefits, or what's the average payment rates for a certain dental benefit. This would require MA plans to actually submit enrollee level. So for every single enrollee that receives a supplemental benefit, item or service, they would actually be required to see, exactly how much that benefit would cost, or exactly how much enrollees would have to pay for that benefit. It also requires, these certain metrics here, provider payment information, out-of-pocket cost, and then finally, it requires CMS to make a public use file available for enrollees. Next slide. And finally, the last bill that I want to talk about today is the Prompt and Fair Pay Act. This was introduced by Representatives Doggett and Murphy just this year. And this really tries to aim to get MA plans to reimburse providers around the same rate that traditional Medicare would, and also to require them to reimburse providers within certain timeframes. So it requires MA plans to provide at least the Medicare fee-for-service rate for a contracted provider. Currently, non-contracted providers are the only ones who have to receive at least the Medicare fee-for-service rate. And then finally, it aligns Medicare Advantage and Part D by requiring MA plans to provide reimbursement to providers within 14 days for an electronic claim, or 30 days for a non-electronic claim. And those are the three other bills I'll talk about today. So with that, I will pass it over to Carrie.
All right, thank you guys. And we're gonna turn it over to the audience. I want you guys to be thinking about any questions you have on these bills. No question is wrong. We'd love to have a conversation, but I'm gonna start us off with a question for all of you, because we've talked a lot about, the ins and outs of these bills, but open enrollment is kicking off for beneficiaries. Beneficiaries are out there right now, hopefully, looking at different MA plans, making a choice of MA plan versus whether they're going to stay or switch back to traditional Medicare. So of the bills that you all talked about, which ones would change benefits or costs for beneficiaries? Like, how would it change beneficiaries' lives? Anybody?
So, I mean, I can start on that. And so a lot of these bills are focused on the payment issues that are going on sort of behind the scenes. And so definitely for no upcode and for this VA bill, you know, it won't change immediately what's going on for the beneficiary, how they're interacting with the plans. I think where the opportunity to have impact on the beneficiary experience is, since these bills would largely be a payment cut to MA plans, will that lead to plans having a response in turn where they cut back on benefits, where they cut back on networks and cut back on other things that might be attractive to beneficiaries, making the plan sort of less attractive for beneficiaries moving forward. And so I think that that's sort of the biggest risk of what could happen from this legislation for beneficiaries. I think, like, I have maybe some optimism or maybe at least not pessimism about what could happen in this situation, because it is true that the plans will make less money in these situations, but the plans tend to do quite well. I will also say that, you know, MA plans are very different from one another. There are some MA plans that are doing a lot more coding, that are doing a lot more VA work. Other MA plans are doing a lot less. And I think it's really important to distinguish that we shouldn't think about MA as sort of one monolith. So I think some plans will respond, potentially by cutting back on some services, but the MA program is a competitive market. And if a plan cuts back on too many services, if they increase their premiums above the $0 level, they're going to be at risk of losing a lot of members to other plans. And that's what we've seen in the past, is that these competitive pressures often keep plans at least a baseline level of sort of quality, network design, and other sort of requirements. So there's a risk of it, but I think it's important not to overstate what those risks are, because plans still need to keep members enrolled.
I think I can go next. So the Improving Seniors Timely Access to Care Act, kind of one of the big key things is it's going to start requiring prior authorization metrics at the plan level, which, although beneficiaries don't often look into like that data on their own, they might not know exactly what these numbers mean. There will probably be a lot of researchers and a lot of like Forbes articles or, you know, other folks who are familiar with the topic who can use that information on prior authorization metrics and kind of give a rating to these MA plans and say, hey, if you need this service a lot, you might get denied a lot at this plan. And we know it because we can see it now at that local level. So I think that might be something that can come from the Improving Seniors Act, Timely Access to Care Act. Or CMS might see that data and say, hey, maybe we should be publishing this on the Medicare Plan Finder. So I think that might be one of the biggest opportunities, at least on the Improving Seniors Timely Access to Care.
So I'll follow up with you again, Ciannah. So prior authorization has definitely been in the news. There's been a lot of pushback from health systems and lawsuits and people on TikTok talking about how frustrated they are with prior authorization. And so we know that a bunch of MA plans got together and made a voluntary pledge saying, we are going to speed this up. So why do we need, if there's this pledge out there, why do we need Improving Seniors Timely Access to Care Act?
Yeah, I think there are definitely arguments for why we might not need it because of this voluntary pledge. Like that pledge kind of, it's a bunch of plans who have decided we're going to try to get up to 80% of real-time decisions by 2027, which is a great goal. And I think that's awesome. But there's a lot of folks who would argue that it has no teeth. Like if that number is not met, if these standards are not upheld, nothing really would happen to those insurance plans. And it's also not across the board. So not every insurance plan is part of this pledge. And so I think just kind of creating that standard kind of more of an incentive than just let's do it, you know, like that might be the biggest reason for why this legislation would be necessary.
All right. And you talked a little bit about how MA plans might respond to this. Jackson, do you have any other thoughts on how the industry might respond to something like no upcode?
Yeah, definitely. So, you know, a little bit going back to the previous question, just about what no upcode would mean for beneficiaries too. So agree with David's points. You know, there is around the time of the year ahead of the spring rulemaking where we start to see plans say that, you know, the industry's in turmoil, you know, years of cuts have led to reductions that are going to be seen next year, all these different factors. But similar to what David said, I just want to make it clear, right, that these are businesses. These are private businesses that are carrying this out. And at the end of the day, we know that businesses like to protect their bottom line. So with that, I think in terms of no upcode, what it could mean for beneficiaries as well is just recognizing that this is a massive federal program. It's $450 billion that we spend every year on Medicare Advantage. It's also a program that Congress hasn't really looked at in a substantive way in the last 20 years or so. At the same time, in Congress, there are people that want to bring a lot of improvements to traditional Medicare, out-of-pocket cap, additional benefits being offered to TM beneficiaries as well. So I think how I take this question a little bit too is also to think of what those savings can actually bring to reinvesting traditional Medicare and making sure that everybody's care improves.
One thing I'll just sort of add to that specifically with the VA bill is the VA is often under budget threat when it comes to sort of cuts that it might be facing sort of in each year. And what something like the GUARD Act or other similar legislation could help provide relief to the VA's budget that they're now spending all this money on these beneficiaries. And if they're able to recoup that, then that could help, keep more lights on at the VA and keep provider levels up. And it's sometimes the VA kind of gets a bad rap, but generally care satisfaction is very high at the VA. It ranks higher than sort of most hospitals and most other health systems. And I think, making sure it could benefit beneficiaries if the VA is sort of adequately funded.
The other thing with no upcode is that when you talk to beneficiaries, so these health risk assessments that they hire a company and they go in person to your house, beneficiaries like it. They're like, gosh, my plan is sending someone to my house. They care about me. They're asking me about my healthcare needs. And there's a reason why health risk assessments are required in dual special needs plans, because they're supposed to provide coordination. They're supposed to provide an opportunity to find unmet needs and get them the care they need. So I'm wondering if you see that, Jackson, as sort of a pushback on, the MA plans that aren't required, would there be less likely to do these health risk assessments if they can't mine for diagnoses there?
Yeah, I mean, it is a fair question. And the other thing I'll say too, and this is, I think, why this panel is assembled this way to look at beneficiary side and more of the program integrity side too, is that for upcoding, it really isn't a beneficiary experience thing, right? They, of course, experience the HRAs. They would have their medical records reviewed under a chart review. But in terms of the care that they're actually getting, as long as that's being carried forward, then, they might not even know what upcoding is, and that's being done to them too. So I think the side of it as well that, upcode is really trying to get at, and this kind of fundamental statement for the MA program is that we should be paying for care and not codes at the end of the day. What this patient experiences when someone comes into their house and maybe takes their blood pressure and talks to them about their nutrition should actually lead, if those things are not in check, to the patient then seeing their preferred medical provider and actually getting care for it as well. So I think bridging that jump between how we're actually incentivizing care for these beneficiaries is part of what the bill tries to get at.
I think something, I think these HRAs, it can be a valuable experience if the HRA is able to capture somebody, if it has somebody who's homebound, is able to connect with somebody and have that experience. But I think what's important about the way no upcode does, it doesn't say you can't do the HRAs. It's just if you're going to get paid for something that's caught in an HRA, the person still needs to show up and receive care. Because if the HRA is identifying that somebody has 6 conditions, and then that patient never receives care for any of those conditions, then that's not high quality care, and that's not in the patient's best interest either. And so I think what this is trying to do is make the incentive structure match the care structure, or align the incentives better between getting people into the office if they actually do need that care that the code might indicate.
I want to turn it to the audience now. We'd love to hear any questions you have.
Thank you, everyone, for your time. I come from laboratory world, just to give that context, and genetic testing in particular is something that we work on from a policy perspective. And just to be candid, there's a lot of fraud associated with genetic testing. So there's a lot of focus on utilization of those services, rightfully so. But something like, for instance, David, you were sort of touching at is like the pros and cons of legislation or some of these proposed solutions where for better or worse, you're just also disrupting perhaps some legitimate access to care when you propose solutions. So I was wondering, you know, I would love to hear your thoughts about finding that balance between the solution versus disrupting patients who really do need that service, and where do we find that? Or if you could wave perhaps a magic wand acknowledging it's really complicated and propose a better solution, like what might that be?
Your question, David.
I can start on that. So I mean, I think
Help
it's a
you
really,
out.
I mean, I think it's a really great point that when Congress makes a policy decision and tries to change something, that can lead to disruption. I think sometimes though, there's a little bit too much of concern over disrupting the status quo when the status quo isn't something that's working for a lot of people or isn't working sustainably when it comes to the amount of money that's being spent on these programs. And I think that we need to be careful to really think about what are all the possible outcomes that can come from this? What are the negative ramifications that can come from this? And talk to everybody, talk to all different stakeholders when these policy processes are coming together. But I think it's really important that we don't use potential disruption as like a reason for not changing things when there are clear problems with the way payments going and in general. And
Is that your experience that you, like people would rather change and keep status quo as opposed to even proposing another solution?
I mean, the MA program hasn't had any serious pieces of legislation in over a decade because I think there's often sort of this concern that if Congress rocks the boat too much, CMS can also do a lot more than what they're currently doing under their current authorities, but they don't do it because it could rock the boat and it could create sort of these challenges and it leads to sort of these status quo issues. And so I think it's really important to think about what the outcomes of the legislation are going to be, but I think it's just really important that people don't get crippled by that if we want to see these programs move in a direction that maybe in the long term are spending money more wisely to actually benefit, you know, beneficiaries in the Medicare program.
We'll say too, when he mentioned both fraud, waste, and abuse, and a magic wand and things that can be done, you know, even right now, CMS's existing mechanism for rooting out overpayments or waste, fraud, and abuse in the Medicare Advantage program is the risk adjustment data validation program, the RADV program, where CMS, you know, will go through individual diagnoses and the medical record and just make sure that diagnoses that are submitted by MA plans match what's in the medical record and recoup overpayments. One of the issues with that is that they look at a very, very small sample of these due to a recent court decision. They can no longer actually extrapolate the findings across the entire contract. And it makes it really, really difficult for CMS to use that authority to actually root out some of these payments. So, you know, one of the things that legislation could do is expand that existing RADV program, you know, give it a little bit more teeth, audit more contracts, or be able to extrapolate across, you know, entire contracts to really rein in some of those overpayments.
You know, maybe.
One of the things that's top of mind for me is that, you know, there's a Healthscape article that came out a couple of weeks ago that talked about local and regional nonprofit health plans are running at negative operating margins. My home state of Minnesota, UCare just exited the MA market. The national level, another small health insurer in Minnesota, United Health Group, is closing a bunch of, or is shutting down a bunch of plans that were not profitable. And so to me, like, I buy the argument that there's like a lot of money that could be pulled out of the system. And at the same time, there's like these insurance companies are operating at 3 to 4% margins if they're doing really great, and negative 2 or 3% margins if they're not. And it seems to me like, you know, there's just not enough competition in the markets, and pulling more money out of the markets is going to lead to less competition. I'm curious I'm curious for your reactions on that.
Maybe Gary should take them. I just want to say that I think it was David or Jackson who said there's great variability in MA plans in terms of their mission, their structure, and how they operate, how much they upcode or rely on HRAs or different things. And we know it's a priority of the current administration to ensure competition around these small non-national plans. And a lot of times policy gets set by the the big five, big national plans. And then people sort of look at those and they think the behavior is the same. And so there are some policies, for example, we talked about the coding adjustment, everybody's coding goes down 5.9%. What if you had coding adjustments that were different for different plans that showed different behavior in terms of how much they're upcoding? Or what if RADV audits were focused on plans that were showing that they were bad actors in some of this? So I think that there's some opportunity for really taking into account the differences in this field to be able to ensure some of these small plans are, they're really located in the community. They are trying to have their supplemental benefits match what is needed in their communities. They have offices in their communities where people come together. So, they're very different. And I think that there are some policies you could do to adjust, and you guys probably know more.
I think just one more thing I wanted to comment on about that. I mean, I think the competition point is a really important one, but I actually am more of the view that the current status quo is the uncompetitive dynamic here, because you have a few major national players that are able to do more coding because they have more money to invest in coding or invest in the HRAs. And it allows them to compete in their markets in a way that the smaller regional players just don't have the means to be able to compete at that level. And so in some ways, some of this legislation could help even the playing field a little bit, so that you don't have one or two major plans that have the opportunity to code a lot more, sort of squeezing out smaller plans from being able to engage in the same activity.
Just thought it'd be a good opportunity to chime in to build on the because I work for a DSNP, a local community-based DSNP, and I wanted to ask about a question about the Upcode Act. Good that we're talking about progressive coding intensity adjustments. We like that. Although I would say we are concerned about lack of ability to use chart reviews to find our diagnosis codes. And this is something that this is one of those things that may actually benefit the big plans because they will just put coders in providers' offices, and we will not have the ability to do that. And as long as we are building the risk adjustment model and payment on diagnosis codes, David, we have to be able to find those. And so the problem is, and Jackson, you're totally right that there's a difference between the codes in fee for service and the codes in MA. That's because, as you point out, the incentive, but because there's no incentive to code properly, or providers don't have an incentive to code properly, they don't. So they're arguably, the fee for service codes are undercoded. And so we need to, we're sitting at a 96% MLR, and one of those plans has a negative margin. And we have the highest acuity members as dual eligible members. So we really need to make sure that those diagnosis codes go in the risk adjustment model. And we see providers coding based on procedure codes because that's how they get paid, right? So they don't care if the diagnosis says depression or chronic depression, which pays higher, but we have to have people go look in the notes to find those words, recurring, chronic, so that we can code that chart properly. So, if we didn't have the ability to do that, we would lose much more money, probably have to try to pull out of the market, even though our state requires us to be in it. But that's a tough one for us, Jackson. I just wonder if you see anyone looking at that on the chart review side. It's nice that they're looking at coding intensity adjustment because, yeah, we're coding less intensely than the big plans. But any possibility of doing something for us little guys on the chart review?
Yeah, I mean, it is a fair question as well. And again, I think I would go back to two things. One of which was a point David made as well, just that we shouldn't have a system that's incentivizing the structure to need to do that in the first place. For you all as the small plans to feel like you really need to do a lot of that to really keep up with the larger plans at the end of the day. So I think that's one point I would come back to on it. And the other point I would say too is really, again, what the fundamental message is for Upcode is that, those chart review diagnoses then should be used to better coordinate care for beneficiaries at the end of the day. So making sure that it actually does come back to an encounter and have that recognized plans are engaging with the patient, I think is some of the ways to address that a bit more. again, right, it's, going back to the example I put on the slide, right, it's like the big plans that can go out and hire Charta to come in and mine for these codes at the end of the day. And so if we can remove some of that incentive structure, I think that would be best way to address it.
So just sort of thinking about like what a robust, healthy MA market could look like or should look like, especially from a beneficiary point of view. And I think, David, one of the things you point out is like maybe one of the sort of unintended consequences of some of these policies could be plans are pulling back some of their more generous benefits, or if they are, exiting the market or not offering quite as many plans. I think that can be potentially concerning, but I think, there were a lot of articles that came out recently about like the average MA beneficiary this open enrollment only has access to 32 plans on average, as opposed to like 36 plans or whatever it was last year, right? And it's like, I don't know that if generally speaking on averages, that's necessarily like the sky is falling. I would maybe argue as a bit of an economics background, that's maybe still too many plans and too many choices, and therefore people can't make good choices fronted with that many options. But, and it's more about, sort of quality than quantity, certainly. But, sort of how should we be thinking about like if one of the maybe consequences of some of these policies is a reduction in generous benefits or a reduction in plan number offerings, et cetera, like what should we actually be thinking about instead in terms of like, what do we want a robust and a healthy MA market to look like, regardless of where you are?
So there are a lot of barriers to Medicare beneficiaries making informed choices. This entire MA plan is based on this idea that we will have a free market and people will choose higher quality plans and lower price, and it will drive quality and prices. And it seems like we've had this, that has morphed into more plans is better choice. And so if I think back to what Ciannah was talking about, there are things like beneficiaries don't really maybe see the full scope of the supplemental benefits that are provided, especially these special supplemental non-medical benefits. They might not be able, when they're choosing, to know what the scope of those are, what the eligibility is for those. If they look at the 5-star rating for quality, they're seeing a 5-star rating sometimes across 300 plans in 11 states. Doesn't mean anything about their plan. So I think one of the most important things is kind of shifting this idea of more plans to really getting clear on this idea of beneficiary transparency, being able to go and really see the difference. People say, oh, well, beneficiaries don't use those 5-star ratings. Well, they're meaningless for beneficiaries because they're not even seeing their plan in their market. So there are so many major problems with really being able to make a clear choice with all the AI and all the tech, this tech forward administration. It seems like we could do better than Medicare Plan Finder and have a lot of really specific information that, maybe we would get the benefits of a free market if people could really choose these high quality plans. So to me, a good market starts with really being able to see what you're buying.
And I think on that, I'll talk a little bit about this provider directory bill because, it doesn't sound, I think like when people hear, oh, inaccurate provider directories, like that's probably not a huge deal or not that big. A Senate Finance report found that about a third of the provider directories they looked at actually had massive inaccuracies or the providers were completely out of network. And that went up to 80% when they looked at mental health and behavioral health providers. So, if you want to make sure that your doctor that you see is in your network, you want to really ensure that the provider directories are accurate. And so these accuracy scores are going to be really important as another way to kind of, possibly supplement star ratings as another mechanism to really, ensure you're finding the plan that best meets your needs.
So thank you so much for the presentation. Patricia Kalmarm with PERG, the Consumer Advocacy Organization. So a lot of these solutions focus on fixing things for the plan, right? But I work with a lot of patients that call us with all their medical bills. their interaction is primarily with the provider, and I'm just curious, for the provider directories, CMS had put out a proposal a couple of years ago to say there should just be a national provider directory where the providers are responsible for listing who they're with. And I think that's how the consumer thinks about it, right? They have their favorite providers. Wouldn't it be great? They could just look them up and then see, these are the 6 plans in my region. And then the 32 plans doesn't matter to them because they really care just about that one provider. So I was just thinking about if we could get some level of that. And then the other issue on the prior auth, we have a lot of patients who there may be very clear prior auth, but the doc who's ordering the stuff doesn't know it or doesn't share the information in a way that's helpful, or doesn't share it ever. And oftentimes the patient is left out there, right, with a claim, with an unpaid claim that the provider said was an emergency. It's not necessarily an emergency. It should have had prior auth. And then the patient can't get the provider to help with that claim appeal. And we let them off the hook, and we can't. So I'm wondering, in the prior auth bill, is there a way that we can put a little impetus on the providers? I mean, I don't want to bring on more enemies in a bill that maybe has a chance to pass. But on the other hand, from the patient perspective, I don't see it really working as effectively as it could.
Probably everyone in this room has been going through a health crisis and has been on the phone with their insurance company trying to get the information to the insurance company. It's, the providers spend a lot of time with prior authorizations, but the patients do too. I've been in that situation. And I think that one thing, we just did a briefing, and we had a gentleman who is the CMO at an MA plan, and he said, if we could use AI, everyone's afraid of AI, and there's all this AI coming out, but what if AI could tell the provider before they even submitted, you need to submit it this, and this way, right? And so it would stop them from even submitting the claim without the proper. So they don't submit the claim, and then a week later, the health plan gets back and denies, and then a week later, they do this, So ways to kind of help the provider use all this technology. Any other?
I will just say that the Improving Senior Timely Access to Care Act, it requires like an explicit, clear publication of all the items and services that are subject to prior authorization. I didn't mention that explicitly, but so that would be like a clear way of making sure that physicians and providers are aware of exactly what is going to be subject to prior authorization, which I think right now it doesn't have to be quite as explicitly provided to them in that way. Neil, I'm not sure if you have much else to add there, but yeah, I mean, as it stands now, I don't think it addresses the issue that you mentioned, but maybe in the future.
Yeah, I think it might have been the other bill that you mentioned. I can't remember the name exactly. Reducing unnecessary delays in care, medically necessary delays in care. It did require that the MA plan has to make the provider along with the enrollee aware of the determination, and that the provider would have to basically at that point get involved in the determination process, and then, could submit the appeal, it essentially would give the provider a lot more authority to sort of get involved in that process. And I can't remember the exact details, but I also wanted to address your provider directory question around the National Provider Directory. So I think you're right. A few years back, CMS had put out a request for information on a National Provider Directory. And currently there is the National Provider Enumeration System, NPES, which basically is the closest thing we have right now to a National Provider Directory, but it doesn't include all this information. And when CMS was going back through, this NPES system, they were finding, well, we actually have the same problem that MA plans have, is that we have a lot of inaccurate information. And really, one of the issues here is that in the MA program, CMS can enforce things on the MA plans, but there's no real mechanism for CMS to enforce things on the providers of those MA plans. And that's why the framework of this bill is really, and same with improving seniors, is really based on what the MA plans can do. I do think, though, it is just fundamentally really important for providers to be giving that information to the MA plans, or something like a national provider directory where they're submitting it to CMS. But CMS really only has enforcement over Medicare contracted providers in the traditional Medicare program, which aren't really always the same.
Well, we've run out of time, but we would like to say, contact us. I think we'll be lurking around here for a little while, but if one of the things we do is we provide technical assistance to policymakers in Congress, and our website is there. You can contact Neil, who is in charge of our technical assistance practice. And I'm sure you could contact Jackson and David as well. We'd love to continue to hear your questions. We'd like to continue the conversation. If you're interested, I would also say that we have several publications on our website, which is here. We have one on beneficiary choice. We have a prior authorization fact sheets that were funded by West, and a lot of different information there. We actually have a brief. We did a small to medium size non-national plan, close to a roundtable. And so we have a brief on what we heard from the smaller non-national plans in terms of the policies they would like to see happen. So I'd encourage you to go to our website if you're interested in hearing more, and we'd love to continue the conversation. So please reach out. And I want to thank you guys. Thanks, David, for coming all the way down from Providence, and Jackson. And hope to see you all again soon.